right, so are people at a distance? If you have your cameras that you can turn on, that'd be great so I can see you. But we'll go ahead and get started here in just a minute. But before I go and get started with the presentation, maybe I'll just have the people who are here introduce themselves, and maybe we could start with Pearl.
Sure. I'm Pearl Walker-Sweeney. I'm the INBRE project manager here at NDSU.
I'm Bernhard Seineidekut. I'm in the Department of Geosciences here at NDSU.
I'm Allison Goldenstein. I'm the graduate assistant for the INBRE program.
Yeah, and as you know, the INBRE is the Idea Network for Biomedical Research Excellence. So that's the grant that helps to fund some of this work, including more engagement with tribal colleges and other groups to try to expand awareness of research opportunities and research careers. And Pearl is a member of both the Standing Rock Sioux Tribe as well as White Earth Nation. So it's good to see at least there's one Lakota and Chippewa who can get along. And then we have Pearl. And then it's also wonderful to have one of our researchers here who's assisting with the air quality study at the Mandan Hidatsa Interrecored Nation. So my name is Donald Warne, and hopefully I've met most of you out there. Don't see your faces yet, so when your cameras are ready, please go ahead and turn those on. I'm Oglala Lakota, originally from Pine Ridge, South Dakota, and actually from a small town called Kyle, South Dakota. And I'm a physician, also have a master's degree in public health. I'm the chair of the Department of Public Health here at North Dakota State University. And we have the only Master of Public Health in the nation with an American Indian specialization. So our students can actually get a master's degree in American Indian public health. So when I start these discussions, I always like to frame it from a more traditional perspective. What is public health? How does it apply to our communities? And also, how does research fit into that model? And I'm sure many of us are aware of the traditional story about three sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. The first sister jumps in and says, "This is a crisis, it's an emergency, we need to get the babies out of the water right away." The second sister says, "No, we need to teach them how to swim so they can survive while they are in the water." And the third sister just keeps walking upstream. And the other two ask her, "Where are you going? Why aren't you helping us?" And she said, "I'm going to find out who's putting these babies in the water, and I'm going to stop them." That's public health. That's working further upstream and trying to make an impact on preventing issues rather than waiting until they become a crisis. So when I look at public health, in many ways, focusing on wellness, health promotion, disease prevention, is in many ways consistent with traditional medicine from a cultural perspective as well. Also, research does fit into that, and that'll be our topic today, is to look at research issues in tribal communities, particularly in the Northern Plains, but how this fits into not only a scientific paradigm, but also a cultural paradigm. So when we look at the Indian Health Service areas, we know there are 12 regions or areas of the Indian Health Service, and they're outlined here on this map. And when we think about health disparities with American Indians and Alaskan Natives, we have to recognize there's a lot of diversity within Indian country, that there are hundreds of tribes, hundreds of cultures, hundreds of languages, and the patterns of health challenges vary across the different regions or areas of the Indian Health Service. Unfortunately, in the northern tier of the U.S., really the Billings area, the Great Plains area, and the Bemidji area of the Indian Health Service, we tend to see the worst health status. And certainly here in the Dakotas, we tend to see bad outcomes, early age at death, and high rates of preventable chronic diseases. So the question is, why is that the case? Well, that's actually a research question. Why is it that we have worse disparities in our region? There's social determinants, cultural determinants, poverty-related issues, other factors, but the only way to understand or to discover why we have these disparities is to go through a research process. So that's part of the framework, is that the whole research process allows us to answer some very challenging questions. Here's a little more information on our disparities. When we look at the Great Plains area of the Indian Health Service, again, that's North Dakota, South Dakota, Nebraska, and Iowa, we tend to see about 10 years difference in life expectancy. Now, life expectancy at birth is how long you would expect someone to live who is born this year. So it is a projection. It's based on scientific principles. We use different types of algorithms and scientific models. But in truth, it's our best educated guess as to how long people will live who are born this year. Whereas when we measure average age at death, that's not a projection, that's actually looking at a cross-section within a given time frame. So if we look at, for example, between 2005 and 2010, the average age of death in North Dakota was 75.7 years for the white population and 54.7 years in the American Indian population. So that's a difference of 21 years in average age at death. And in many ways, we can look at the American Indian population in our state in terms of health status. It's like a third world nation, that our people are dying on average at age 54. In the community where I am from, in Pine Ridge, last year, the average age of death for men was 48. I'm 50. So I guess from here it's all gravy, right? You know, kind of past the average age of death. So, but it shouldn't be that way. It doesn't have to be that way. So how can we improve life expectancy for American Indians? Again, that's a research question. We don't have all the answers right now. The only way to get to those answers is to go through a research process. So what are we trying to do about it here at NDSU? We do have the Master of Public Health degree program and 4 specializations within it. We have health promotion that leads to eligibility for the community health education specialist credential. We also have management of infectious diseases, community health sciences, which has just recently changed to public health and clinical systems. And then we have American Indian public health. And again, we're the only program in the nation with American Indian public health. Every student, no matter what track they are in, takes the same 18 core credits. And that's things like biostatistics, epidemiology, leading and managing public health systems, and those types of basic public health courses. And then there's 18 credits of specialization classes as well. In the American Indian track, we have 5 required courses. It includes American Indian Health Policy, in which we look at the legal and historical basis for Indian Health Service and the work that we have through the Public Health Service for the United States. Also, we have American Indian Health Disparities, in which we look at the different patterns of disparities around the nation and looking at some of the root causes and social determinants of those health disparities. We also have cultural competence in Indian health, recognizing that there are hundreds of American Indian cultures, not just a single American Indian culture. And we also have other areas that we need to be cognizant of, like the culture of poverty, for example, or the culture of chronic disease. And we examine those at a deeper level within that class. We also have research issues in tribal communities, which I'll be talking about today. But in that particular class, we go into much greater depth. So what we're going to be covering today in 1 hour really is a semester-long worth of information, kind of boiled down to the real basic points. And then finally, we have case studies in Indian health, where we have an inventory of best practices and promising practices in terms of public health programs that are working and why they are working in Indian country. So if anyone's interested in pursuing a master's degree in public health, just let me know and I'd be happy to get you more information. But for today, let's really look at the research issues in tribal communities. So when we think about public health, there's actually 10 essential public health services that have been identified by the Centers for Disease Control and Prevention, or the CDC. And you can see them here. We have monitor health status in the community, diagnose and investigate health problems or health hazards in the community. We also inform, educate, and empower people about health issues. So for example, with tobacco control, CDC has funded a lot of programs that develop things like programs and educational services and commercials to help people try to quit smoking or avoid smoking, for example. Number 4 is mobilize community partnerships, recognizing that there's not a single agency that's going to solve all of the health issues, and public health is multidisciplinary, so we need to be able to work across multiple disciplines within our communities. Number 5 is develop policies and plans. And for us in tribal communities, we also have to recognize that we have one extra layer of government and one extra layer of policymaking with tribal leadership. So when a tribe goes through the process of taking over the management of their health programs, for example, under Public Law 93-638, Indian Self-Determination Law, then the local tribal leaders also become health policy makers. So we have a lot of complexity just thinking about the essential public health services in tribal communities, and we have extra layers of policy making and lawmaking, essentially, that has an impact on public health. Number 6 is to enforce laws and regulations. That's a kind of a big issue right now, especially when we look at environmental health and the Environmental Protection Agency, and with all of the political challenges that we're seeing and some of the regulatory authority potentially being threatened with the new administration. It's a huge impact on us here in North Dakota with all of the different types of industries that have an impact on the environment here. But so that's considered one of the public health services because the environment does have an impact, obviously, on the health of populations. Number 7 is to link people to needed health services. So for example, a lot of what we do in public health is to ensure that people get screened for screenable cancers or preventable diseases. So if we don't screen for things like cancer and it's diagnosed late, people can die unnecessarily. Whereas with good, strong, and effective public health services, we're trying to promote outreach and engagement with things like screening programs and linking people to services to improve outcomes. We also want to assure a competent public health workforce, and that's certainly what we're trying to do here with our program here at NDSU. Number 9 is to evaluate programs for effectiveness, accessibility, and quality. And program evaluation is vitally important so we can build our evidence base for things that are working in our population specifically. So those are 9, and the 10th essential public health service is research. And the role of research is to find innovative solutions to health problems. And obviously, as American Indian people, we have a lot of challenges in terms of health status for our population, higher rates of disease, disability, and death, and much of it is preventable. So we need new insights and innovative solutions to address these health problems. So research is absolutely vital in terms of linking public health services to our populations, but doing it in the most effective way possible. So this is the public health wheel. Again, it's the same 10 services in terms of monitoring health, diagnose and investigate health problems, inform, educate, and empower the community, mobilize community partnerships, develop policies, enforce laws, link people to services, assure a competent workforce, evaluate programs, and at the core is research, because research will allow us to identify new ways to be more effective in every one of those other 9 domains of public health. So when we go through the course, Research Issues in Tribal Communities, these are the objectives, and it's called MPH 774, and it's the Research Issues in Tribal Communities. And we look at describing models of community-based participatory research that have been conducted in tribal communities. A lot of our tribes now have their own institutional review boards, or IRBs, and more tribes are starting to establish their own research agendas, which is really wonderful to see. So as tribal communities, we shouldn't just be studied, we should be driving the research agenda to make sure it's meeting our needs. But we also have to be culturally appropriate in the research process. I think that when we think about the culture of academics, it's got very different values and priorities than many of our traditional cultures. So we have to do this in a culturally appropriate way, and that's part of what we talk about in this course. Also explain the role of research, educational programs, and partnerships with academic institutions in reducing disparities. One of the advantages we have here in North Dakota is that we have tribal colleges within each of the tribes. That's not the case in other states. And interestingly, in North Dakota, we have 4 federally recognized tribes that are based here in North Dakota, but we also have 5 tribal colleges, because United Tribes Technical College is located in Bismarck. Also in the course, we describe case examples of successful research and why it was successful, but also unsuccessful research projects. And unfortunately, there have been case examples where research was not conducted appropriately, and in many cases, it builds a sense of distrust toward the research community. Then we also describe the roles for epidemiology, which is the study of epidemics or diseases in populations, the role of clinical trials. So a clinical trial is testing new medications or new interventions. Health services research is where we can assess the effectiveness of how we provide services. So for example, we could test the effectiveness of a tribal 638 program as compared to IHS federal program to see which is more effective. That's health services research. And then basic science research, even identifying, for example, perhaps unique genetic components to health challenges that we are facing. Even looking at epigenetics and how stress within one population potentially could have an impact on subsequent populations, and really try to understand even the basic science of historical trauma. So we have all kinds of things that we could do when we address research issues in tribal communities. So our task is then to identify what should we do and how should we do it. So we use these resources. These are relatively new publications. On the left is Conducting Health Research with Native American Communities, and that was published by the American Public Health Association. Several of my friends and colleagues were editors and authors of that book. We also use Research is Ceremony, which was written by Sean Wilson, and he is First Nations Indigenous person from Canada, and he actually wrote that book as part of his experience becoming an academic and getting his own PhD, and looking at how the research process has correlations to ceremonial processes and how we can look at research really from a more traditional perspective. And then finally, Research for Indigenous Survival, and that one's really focused on research methodologies in behavioral sciences. And as we know, unfortunately, we have higher rates of things like depression, anxiety, and then people are self-medicating with things like alcohol and other substances. So we have to identify culturally relevant solutions to these challenges. There's also a couple of other reports put out in the last decade or so. The one on the left is from the National Congress of American Indians. It looks at research that benefits Native people. And then on the right, out of New Mexico, is Guiding Principles for Engaging Research with Native American Communities. So we use all of these resources in this particular class. So we'll boil down a semester's worth of graduate material into 55 minutes or less. So we'll see how we can do. Just thinking about the history, unfortunately, with a history of maltreatment, history of abuse, long-standing intergenerational poverty and poor health, there's a long-standing history that's evolved in many cases toward distrust. Historically, we did not have a lot of our own people who were in academic sectors. We did not have a lot of researchers. So the research community was always viewed as the other or the outsiders. And quite often the research would be brought to tribal communities, and there's a term that was coined called helicopter research, where the researchers drop in, collect their data, fly out, and they're never heard from again. So how did that actually benefit the community? Unfortunately, some tribes really feel like they've been overstudied. I used to work with the Pima Indians in Arizona, and they've been studied by the NIH, the National Institutes of Health, since 1963. And they've basically been doing observational epidemiology, looking at the trends of diabetes in that community. So while they have spent hundreds of millions of dollars on research in this particular tribe, the diabetes rates have still gotten worse, even though the researchers have been there. So what is the benefit from a tribal perspective? So I think we have to recognize that with this history of sometimes poor relationships and improperly engaged communities on behalf of the researchers, and then really not focusing on community benefit, we've developed distrust in many cases between tribal communities and researchers. So how do we try to overcome that? I think we have to recognize that we have different cultural perspectives. Historically, with storytelling, like the story I started the discussion with about the three sisters walking along the river. We have learned a lot of lessons, and we pass those lessons on to future generations through storytelling. And much of that is based on observation, and it's based on our own indigenous research methodologies. So quite often we have very meaningful lessons that are passed on from one generation to the next, and that's done through our own culturally based research process, even if we didn't call it research. But we do recognize that there are differences in cultural perspectives, and science is very objective, distant, and factual. So we try to look at purely objective evidence, which I think is important from a scientific perspective. But in many of our cultures, we're much more subjective, and our perspective has an impact on outcomes within the community. And when we're trying to study basic laboratory science, and maybe just working with blood samples, for example, that is one way to be very objective. But what we have to recognize is that public health occurs in a community context, and it's not a pure, sterile laboratory. We have all kinds of social factors and social determinants of health, even income levels, educational opportunities, even how we relate to each other has an impact on health outcomes. So we have to balance the need for good objective science with understanding that local cultures have other factors that come into play. Also, other considerations: sovereignty and control of research. Tribes are sovereign nations, so tribes should be able to control the research that's occurring within their communities. So in many ways, this is different than working with West Fargo, for example. West Fargo, of course, is a city, but it's not considered a sovereign nation. And as a sovereign nation, we can choose to, for example, own the data that comes from our communities. And from a tribal perspective, then we can have much more control of the research that's occurring, but also potential ways to use the outcomes of that research. So we had to look at the values. What are the values of research in terms of advancing science, and comparing that with the values of the community in terms of promoting cultural awareness and cultural competence. Sometimes those things can be at odds with each other. I'll give a couple examples later. We also have to value partnership and recognize that when researchers are working with tribes, that needs to be an equal partnership. The tribes cannot just be simply treated as a lab from which data are collected. We have to actually have partnerships in that process. And then when we look at human subjects protections, we're not just protecting the individual people who participate in the research, we need to protect the entire community and also have cultural protections as well. So it does get much more complex trying to conduct research in tribal communities as compared to other communities. And as we move forward, we want to expand the whole idea of participatory research, where the tribes are actively participating in setting the agenda, conducting the research, and assisting in reporting the outcomes as well as developing programs to intervene. So this is from a paper I published about 10 years ago, looking at the differences between historical research paradigms in tribal communities and more participatory research paradigms. So historically, we have a research institution like a university and a funding agency like National Institutes of Health or National Science Foundation. And they work in partnership to get results. And they use some sort of a laboratory setting to get results of research. So where does the community fit in this model? Well, historically, the community has been treated simply as a lab from which data are gathered. So they're not really an equal partner, they're just simply the laboratory, and then the community members are simply research subjects, not really partners. In a participatory paradigm, the community is an equal partner. And from the research institution's perspective, one of the outcomes or one of the results is to have publishable research, so having publications as a result. From the funding agency's perspective, they want to advance science. So every year, National Institutes of Health and National Science Foundation have to testify before Congress regarding what they've accomplished with the many billions of dollars that have been spent on research in this country. Well, from a community perspective, we're not necessarily focused just on advancing science for the purpose of advancing science or publications. I don't know many of our tribal leaders who care whether or not we have an article published in Diabetologia or the New England Journal of Medicine, but they do care about their communities. And results from the community perspective are improving the health of the community. So if we're focused on equal partnership, in truth, if we're showing community benefit, we're strengthening the science and we're strengthening the publications. So this doesn't have to be adversarial. We can look at this really as a genuine partnership in which every component actually has better outcomes through partnership. However, we do have a lot of complexity. So in terms of historical context, we know there have been examples where the research community or even the public health community has not engaged communities as equal partners, unfortunately. There's current social dynamics and current political dynamics. Within social issues, we have a lot of poverty and a lot of poverty-related challenges. And in truth, our social determinants of health also have an impact on the social fabric and the social health of our tribal communities. In terms of political dynamics, quite often we have issues at the tribal politics level, but look at what's happening in North Dakota and legislators trying to limit tribal sovereignty or passing legislation to try to limit the ability to protest, for example. So at the state level, it's very challenging. And then without getting too political, I think a lot of us are very concerned about the new administration. What does that mean for Indian health, for higher education, and for tribal sovereignty? So all of the research that we're talking about that's community-based occurs within a very complex system of social and political dynamics. In terms of very brief history of some of the challenges we've faced, certainly looking at issues related to infectious disease, outbreaks of smallpox, measles, influenza, yellow fever, and otherwise. By the early 1800s, the American Indian population was less than 200,000 people, and it was estimated probably to be about 20 million at one point with initial European contact. If we look at North America and South America, probably about 5 million people living in what is now the United States. And that really bottomed out. We almost were completely wiped out, mainly due to infectious disease, but also warfare and other issues. But our population has rebounded. In the 2010 census, there's now 5.2 million American Indians. If you think about this in historical context, again, probably about 5 million at initial contact. Of course, the 13 colonies were not good for the northeastern tribes. Many of them were completely wiped out due to warfare and spread of infectious disease. The Trail of Tears is when many of the tribes were removed from the southeast and put into what is now Oklahoma. And in that process, a lot of the tribal populations were split apart. Some people wanted to stay in their homeland and others agreed to be relocated to Oklahoma. So that's why we have Seminoles in Florida and Seminoles in Oklahoma. We have Cherokees in North Carolina, Cherokees in Oklahoma. There's actually 44 tribes now in Oklahoma, of which only 4 are actually originally from Oklahoma, but it was that relocation that moved people to that state. Discovery of gold was not good for the California or Oregon tribes, unfortunately. And then what we're left with is a significant loss. So thinking about the social dynamics of our population, we have entire sections of the US in which there are no federally recognized tribes. And the vast majority of our population now lives in the West. It wasn't always that way. We had people who lived throughout what is now the United States. But because of that historical context, our populations are really concentrated in the West. You can see in the Dakotas, there's still quite a lot of us here. In terms of other complexity, Indian Removal Act was when people were removed from the southeast and put into what is now Oklahoma. The reservation system, we didn't historically live on reservations, that's a relatively new phenomenon. For thousands of years, we lived all over the country, but we're really concentrated in reservations. There was the Allotment Act, or also known as the Dawes Act, and that law basically gave male heads of households within tribal populations a 40-acre plot, an allotment. And historically, we never had a concept of land ownership. So the whole idea of you now own the earth was a foreign concept. So unfortunately, what wound up happening is a lot of people just said, I don't believe I own the earth, or a lot of people then sold their allotments because they needed money to survive. And the result is we wound up losing a lot of land and a lot of our resources through that Allotment Act. The Merriam Report is a very famous study, now almost 100 years ago, where they showed terrible health disparities in American Indian populations that led to the Indian Reorganization Act, which established the reservations. So the IRA is what established our current system of governance, where we have a tribal chairman or president or governor, and then a tribal council, so it's like an executive and legislative branch, modeled after what's done in the US, but not necessarily consistent with tribal cultural perspectives on leadership, unfortunately. Then also, of course, Indian Self-Determination and Education Assistance Act in 1975, and that was the law that allowed tribes to take over health services from the federal government. Other components of our history that have an impact on trust. There was a time frame where Indian Health Service did things like forced sterilization. So when women were having babies, if the Indian Health Service doctor determined that she had enough children without consent, they would do a tubal ligation, or tie the tubes without the women even knowing it. So that type of history in the not too distant past obviously has a huge impact on whether or not our people trust the healthcare system, including the research community. Other components of complexity, looking at tribal sovereignty, and again, recognizing that tribes are sovereign nations, and that the tribes determine whether or not they want to participate in research projects. The Commerce Clause is in the U.S. Constitution. It's Article 1, Section 8, and it states that Congress shall regulate commerce with the foreign nations and the Indian tribes. So even way back in the U.S. Constitution, Indian tribes were put on equal footing with foreign nations. So they recognized tribal sovereignty even way back in the U.S. Constitution. We also had many hundreds of treaties that were signed between tribal nations and the federal government. Actually, on the right, that's one example of the many hundreds of treaties. It's a treaty with the Potawatomi Nation in 1846. And it's a very fine print, but at the bottom it says, the United States giving at the same time promise of all proper care and protection. And that was the typical language in many of our treaties. We exchanged land and natural resources for all proper care and protection. Have we received all proper care? We look at Indian Health Service, unfortunately we have not. So sovereignty, another misconception, sovereignty wasn't given to tribes. We were sovereign entities long before contact. So in many ways we are nations within the nation. Again, that's really coming under threat at both the state legislative level as well as the national level with the new administration. And again, Public Law 93-638, that's the self-determination law, which allows tribes to take over the management of health services. And what I've seen just in my own experience, tribes that are managing their own health systems quite often develop their own research portfolios or research systems, even hire their own researchers to work within their communities. And they own all of the data and can really do it within their own self-contained communities. So I think with more expression of self-determination, there's also the opportunity to really have self-determination and more sovereign control of research as well. Another challenge nationally is how do we define American Indians and Alaska Natives? So for Alaska Natives, the reason we don't just call them American Indians, that they have several cultural groups. One of our faculty members, Siobhan Westcott, is Athabascan, and that actually is an American Indian culture. But the Inuit or Eskimo groups in northern Alaska are similar to the Eskimo groups culturally that we see in Siberia and in Greenland and in Canada. So it's not really an American Indian cultural group, it's more of a circumpolar cultural group. Then also when we look at the Aleutian Islands, the island chain that goes into the Pacific Ocean, the Aleutian people are actually more culturally similar to Pacific Islanders than they are American Indians. So that's why we say American Indian and Alaska Native. So why is this important? Well, the people who are enrolled within the tribes that they are from have eligibility for Indian Health Service services. So that's why it's important to define who is an American Indian and Alaska Native. So is that a racial designation or a political designation? And it's actually both. American Indians and Alaska Natives are a racial minority within the United States, but an enrolled member of a federally recognized tribe is actually a political designation, and it gives us the right to access for health services, for example. Was there a question from any citizens?
No.
Nope, okay. In terms of federally recognized, we know nationally there are many tribes that are not formally recognized by the United States. Some of them are recognized by the state, but not by the federal government. But you have to be federally recognized to be eligible for things like Indian Health Service. Then our reservations, some are under the Indian Reorganization Act and are structured with a governor or a chairman and a council. Then others are non-IRA tribes. For example, the Pueblos in New Mexico were actually in existence for thousands of years, but their formal structure actually came under Spanish rule in the 1600s. So they have a totally different system of governance than the Pueblo tribes in New Mexico. So the take-home message here is that each tribe is different. We all have different histories, different governance structures, different cultures. So in working with tribes, in conducting research, we have to recognize that each time we engage a different tribal community, there's a different culture and different history in which we are working. Another challenge that we face is underreporting or misclassification. Historically, we haven't participated in the US Census counts as effectively as other populations. So quite often our numbers are undercounted. And the reason that's important is it does have an impact on some federal funding streams. It's based on the numbers of people in a population. If we look at the census numbers in 2010, we had 2.9 million people who self-identified as American Indian or Alaska Native, another 2.3 million who were American Indian, Alaska Native, and another race or ethnicity. So actually 5.2 million of us who are American Indian, Alaska Native as of 2010. One of the big challenges that we do see is miscoding of race. It's a little known fact, but the person who determines race on a death certificate is the funeral home director. So quite often they don't ask the family member. So in California, is it possible that you'd have an American Indian with a Hispanic sounding last name? Certainly. Is it possible that some American Indians in California are misclassified as Asian American, depending on what part of California they live? So there was a really good study done, now 20 years ago, 1996, that showed on death certificates, over 30% of American Indians in California were miscoded for race. And we can see it's a problem kind of across the entire nation. So there's been steps to try to improve that, but when we're looking at our numbers and trying to have a denominator for our research projects, it gets very complicated because do we count enrolled tribal members? Do we use census data? Do we use statewide data? Do we use CDC data? So we can see it gets very complex just trying to even understand what is the denominator, the total number of American Indians that we're working with. Also, how do we aggregate the data? Quite often we have very small tribes, so we try to lump tribes or tribal groups together. And this is a big issue for particular disease processes. So if we look at cancer rates, unfortunately here in the Northern Plains, we have among the highest adult smoking rates in the nation and in truth in the world. In many of our reservation populations, well over half the adults smoke cigarettes. And not surprisingly, we have much higher rates of death due to cancer. On this particular bar graph, the blue is American Indian population and the red color is the white population. And you can see in the Northern Plains a tremendous disparity in cancer deaths for American Indians. And the highest rates of smoking are in Northern Plains, Southern Plains, and in Alaska. And not surprisingly, that's where we see the worst disparities in cancer deaths. When I worked in the Southwest, it was rare that people smoked. Most of the American Indians in the Southwest did not smoke cigarettes. And if you look at their cancer death rates, it's actually lower. So if you're just looking at the national numbers and you applied that to Arizona, you would not be looking at the correct data set. So the important thing here is to understand how are the data sets aggregated? How are they lumped together? And the need for tribal specific data is so vitally important because we can't just assume that what's happening in North Dakota applies to data sets from the Southwest because the disease patterns and the cultures can be so different. In terms of epidemiology, and epidemiology again is the study of epidemics in populations. One of our challenges with public health data is the fact that we quite often are not included in many data sets. I go to lots of national conferences and quite often I'll see data for Black, white, Hispanic, and other. So we're in the other along with Asian and Pacific Islanders quite often. So I don't know that those data sets that just lump us in as other are meaningful. It doesn't really give us usable information. So how can we be included in data sets even though our numbers are so small relative to other populations? The World Health Organization, or WHO, in 2007 stated that colonization has had a critical influence on the health of indigenous populations, whether it's indigenous populations here in the United States or Canada, Australia, New Zealand, Pacific Islands, anywhere where there was colonization, the indigenous population suffered, and we see higher rates of things like diabetes, mental health issues, addiction, and cancer across the globe with indigenous populations. It's a picture from the World Diabetes Congress I presented here about 3 years ago. On the left is Alex Brown, and he is Australian Aboriginal. In the middle is Terry Ahau, and he is Maori from New Zealand. They're both on faculty in their respective nations in public health and medical schools. And we were on a panel together. We didn't coordinate our presentations, but we wound up presenting the exact same data. It just happened to be Indigenous Australian, Indigenous New Zealand, and Indigenous American Indian. But we had the exact same data sets. We didn't even realize it would be that way. So in Australia, much higher rates of diabetes for Aboriginal people than non-Indigenous people. For New Zealand and Pacific Islanders, the yellow bars are Pacific Islanders, the red is Maori from New Zealand. And across the board, whether it's impaired fasting glucose or impaired glucose tolerance, which is pre-diabetes, new diagnoses or known diabetics, much worse for Indigenous people than non-Indigenous people. And again, I was presenting essentially the exact same data as they were, but it just happened to be different parts of the world. Historically, of course, we had a different lifestyle. We were not confined to reservations. We lived in a very free way, and we would roam. Some tribes do, but most of our tribes did not have permanent structures. So we would live in different parts of the environment based on the food sources. So here in the plains, at least my tribe in South Dakota, we would be on the plains during the summer months, and we would hunt buffalo and gather food. And then we'd go into the Black Hills for the winter months to be protected against the winter conditions. We also had indigenous farming. These are older pictures from the 1800s. Left is Oklahoma, right is New Mexico. So we had hunting, gathering, and farming. Traditional foods are whole foods, healthy foods. It's interesting that there's this kind of resurgence in focus on paleo diets or indigenous diets, and it's basically what we had been doing historically for thousands of years, very healthy food sources. Modern day hunting and gathering is very different, unfortunately, and it's really impacted indigenous populations. We don't have access to those food sources anymore. So what is the impact of the loss of indigenous food systems on health status? That's a research question, and that's a vitally important thing to know, because we could recapture some of the indigenous food systems within our communities if we choose to go that direction. Unfortunately, one thing that's considered traditional food now is fry bread. Historically, we never fried dough. The roots of fry bread are actually in the USDA commodity food program. People doing the best they can for their commodities with flour, lard, and vegetable shortening. They would basically fry dough. And it's the worst type of carbohydrate with bleached flour, and the worst type of fat with hydrogenated vegetable shortening, basically. And now we call it traditional food. Over 1,000 calories in a typical piece of fry bread. Not good, and most of it's not highly nutritious calories. But that's not what we've grown accustomed to because of poverty, loss of traditional food systems, and social dynamics. So what is the impact of the commodity food program on indigenous health? Again, that's a research question, and it's vitally important, but we haven't really quantified that. Other things to think about in epidemiology, again, with life expectancy compared to average age at death, we know that for American Indians nationally, life expectancy is about 4 years shorter. Now that's looking at everyone, all 5.2 million self-identified American Indian Alaska Natives. That doesn't tell the whole story. If we look at, again, just average age of death in North Dakota, here's the more recent data. 76.6 years for the white population and 56.8 for the American Indian population. That's between 2010 and 2014. So the disparities are tremendous, but it also matters which data set we are looking at and how specific is the data set to our people. And just comparing our numbers to national data quite often is not good enough. We need local tribal data to really understand these issues. One of the reasons why our average age of death is so young is, unfortunately, we have very high infant mortality rates. So a lot of our people die before age 1, so during infancy. The infant mortality rate for American Indians is significantly higher than other populations for infant deaths, unfortunately. So that's just looking at it nationally. In South Dakota, where I am from, if you look at a map of the reservations, you can see where they are located, kind of north central South Dakota, the southwestern part of the state with Pine Ridge and Rosebud, and then also kind of on the eastern corridor as well. And if you look at the counties with the highest infant mortality rates, it's basically a map of the reservations. So overall, South Dakota does not have a higher infant mortality rate than the rest of the nation, but the tribal populations or the counties where tribes are located have by far the highest infant mortality rates. Nationally and statewide, it's just about 7 infant deaths per 1,000 births. Every county that's an American Indian county in South Dakota, the infant mortality rate is over 10. And look at Millette County, 18.5. So that's almost 4 times greater, the infant mortality rate. So when we're looking at the data, again, it's important to really understand what's happening in our communities. And when we understand these numbers, then the next question is, how can we prevent infant mortality in our communities? Again, that's a research question, and vitally important research question. Much of the disparity is due to SIDS, it's sudden infant death syndrome. There are many causes of infant mortality, including birth defects or prematurity, so babies born before full gestation. But for us, really it's SIDS, sudden infant death syndrome. And in North Dakota, look at those terrible disparities. Much higher sudden infant death syndrome for American Indians as compared to the non-Indian population. So the question is, why? Again, that is a research question. We need to know why. How are we going to most effectively utilize our limited resources unless we know the root causes of these disparities. And we need to develop plans and programs and evaluate those programs to show that we can prevent this. It is preventable, but we need to know the best strategies. One big challenge we face, I had mentioned smoking disparities. Babies who are exposed to secondhand smoke have higher rates of SIDS. We haven't quantified SIDS in relation to exposure to secondhand smoke, but maybe that's one of our solutions. Maybe one of the reasons why figuratively our babies are struggling to stay afloat in the water is that they are exposed to adults who are smoking cigarettes. And we need to do something about that. But we've never had a study directly correlating those two issues. Another thing to keep in mind from a cultural perspective is that traditional tobacco is not the same as commercial tobacco. And a lot of our evidence-based practices or what we consider best practices say things like 100% tobacco free. And that's actually not culturally appropriate. We want to be 100% commercial tobacco free. Traditional tobacco, on the left, that's a picture of what we call chinchasha, which is basically red willow. And that is actually medicinal. It's not harmful like commercial tobacco. So if we use best practices that are defined by the CDC and studied in large cities, they'll say you need to have a 100% tobacco-free policy. However, we use traditional tobacco in prayer and ceremony. So when we say 100% tobacco-free, we're saying 100% prayer-free, and that's not culturally appropriate. So we have to be cognizant of the fact that there are cultural differences, and traditional tobacco is not the same as commercial tobacco. Just real briefly, our mortality rates, unfortunately, are also higher for American Indians, meaning American Indians are dying nationally at a faster rate than the non-American Indian population. There was a very good report put out by the American Journal of Public Health in 2014 that kind of shows the overall types of mortality or causes of death for American Indians. And this has the link to that particular document. Another big challenge we face, higher rates of suicide, much higher in North Dakota and South Dakota for American Indians compared to non-Indians. A rate ratio, basically a rate ratio of 2 means twice as many people within the given population are killing themselves. So it's just remarkable how much work we have to do. What is the best way to prevent suicide in our communities? Again, that's a research question, and we need to know the answers to these questions, unfortunately. Another challenge nationally, we have a lot of American Indians who live in cities. So how do we collect accurate data? Here in the Dakotas, the majority of American Indians actually do live in reservation communities, but nationally it's a big issue in terms of cities. And certainly here in Fargo-Moorhead, we have over 4,000 American Indians, but no urban Indian health centers. So they're kind of mixed in with the rest of the population, and we don't really have a good feel, a good understanding for the health disparities in some of our urban populations as a result. All right, just the one thing that I would say, just at the last bullet point in the interest of time, what we really want to move forward with is conducting American Indian, Alaska Native specific studies. And we have to recognize that our interventions and our programs that we conduct in our tribal populations might be very different than what's done in other populations. But we need to test culturally relevant interventions to see if we can make an impact on improving the health of our people. Our future generations really are depending on it. So this is the last slide. Data is power, and again, I'm not sure what's going to happen with this new administration, but generally speaking, you need good data to justify more resources to go into a particular area. If we can show with local data that we have significant challenges that need more resources, it's a much more powerful argument if we have good data. How will we resolve the disparities, and what is the role for research in this process? I think that there are hundreds of research questions that we don't have the best answers to yet, and certainly each community is going to be unique. So we need those tribally specific research projects to move forward to improve health in the long run for future generations. But we do face barriers, You know, there's that historical distrust. Who's going to own the data? And I think what, you know, with what we're trying to do here at NDSU is to be a good partner and be the technical assistance side of conducting the studies, but the tribes own the data. That's got to be the area of focus. And who will lead the way? What are the next steps? And hopefully this will be done in partnership with an academic institution like NDSU, but also partnering with the tribal colleges and the tribal leaders as well. All right, so that was one semester boiled down into 57 minutes. So I know that's a lot of information real fast, but any questions? I don't know if anyone's on the chat.
Yeah, if you guys have any questions, you can feel free to unmute your microphone. Otherwise, you can type them in the chat room too.
Yeah, so time for questions or comments if you have any. But not all at once.
I'm not sure. I think Chindish, I don't know if they got a microphone.
Or if you have to
Out or not. Yeah, I can see they're still on. Oh, so Mike says, how about research funded and done by tribes?
Excellent question. So research funded and conducted by tribes, that is being done in some areas, particularly in tribes that have more resources. The challenge is that research can be expensive. Certainly when we're trying to look at some laboratory analyses, depending on the type of research that we're doing, quite often the equipment that's used is incredibly expensive, which is why it's good to have partnerships with programs that can have access to that type of equipment. But in the long run, that would be wonderful if we could afford to just conduct the research that we need to have conducted ourselves. And there's certainly a lot more autonomy and freedom. When we work with National Institutes of Health or National Science Foundation, their policy is that if they fund research, then it's owned by the entire nation. It's public access. But tribes believe, and rightly so, that they own their own data. So what I've seen in recent years is data sharing agreements where the NIH respects tribal sovereignty, but the tribes also do release data on a case-by-case basis as needed for other studies. So what I would love to see is more capacity, more of our own people going into research careers, going into academics, getting their doctorate degrees, and eventually having our own group of tribally focused researchers. And I think we're getting there. Certainly programs like INBRE are a step in the right direction to encourage our people to go into those fields. But as it stands now, research is an expensive process, so that's why we pursue these large grants to fund it. But eventually, if tribes could fund it themselves, that would be wonderful.
Okay, looks like that's it for questions.
All right, well, it takes us to exactly 4 p.m., so good timing. But if you have any other questions, just get a hold of Allison and email them, and I'd be happy to answer other questions, and the recording will be available as well.
We had some people request slides too. Are you looking at some?
Yeah. Yep, so we'll send the slides as well, so you have the slide deck.
Okay, sounds great. Thank you guys.
Thanks.